minimize suicide, to prevent people from choosing this path. Does it make that harder? Is it going to influence outcomes for people in that way?
That's a very relevant question, and it's one that isn't often asked in this debate, and the answer is yes. If you think in practical terms, when somebody is suicidal and you're trying to dissuade them and you're saying, look, you know, life has a meaning, life has a purpose, things will get better for you. How can you say that with any conviction when you live in a country where the government has passed a law that allows for assisted suicide? What is going to be the deterrent? One of the big deterrents, which is the sort of cultural belief that suicide is wrong, will have been removed. And it's now the case that in several of the countries in Europe, assisted suicide or euthanasia, whatever you want to call it, and I'll talk about the distinction if you need me to in a moment. The distinction has been removed, and the problem of preventing suicide has been made harder, for the simple reason that countries are now allowing euthanasia, assisted suicide, for people with mental health problems. The Netherlands does, and Belgium does. And Canada has such a liberal law that there are no restrictions whatsoever. And in the Netherlands, anybody over the age of 12 can die by suicide, by assisted suicide. In Belgium, sorry?
If a 13-year-old goes to a doctor in Belgium, they can request to be killed.
In the Netherlands, they can, yes, provided their parents agree. In Belgium, they're now wanting to remove all age restrictions so that a child of any age, provided their parents agree, and say a child with cancer or with some kind of neurological, neuromuscular condition, can opt and have assisted suicide. There's a case in the Netherlands of a young woman at the age of 16 or 17 who had been diagnosed with personality disorder and ended her life, and a young woman with autism at the age she was a teenager ended her life in this way as well. So with all of that going on in the background, with mental health, and indeed mental health figures largely in the bill that Kelly has developed, in that the person just has to have a terminal illness. They don't need to be within weeks of death or anything. Once somebody is diagnosed as having a terminal illness, if they are mentally suffering, they can opt to have their life ended. So with all of that going on, how can the government then be having anti-suicide campaigns with any success? And the evidence for that comes from the United States. I can't remember which state it was. It's the first state that legalized assisted suicide.
Oregon.
Oregon. And a study from that, published a few years ago, written by David Patton, who is an economist. He's a friend of mine in Nottingham University. He's professor of economics at Nottingham University. And economists, of course, are interested in suicide because there are financial implications. So he looked at the suicide data in Oregon and found that it increased after the assisted suicide legislation was passed. So the people who die by assisted suicide would not be included in the mainstream suicide data. They would take them out. But even with that, the numbers for people dying by their own hand, dying by suicide themselves outside of the legislation, was elevated. And as well as that, more recently, a Dutch ethicist called Theo Boer, and Theo Boer, B-O-E-R, used to favor euthanasia, used to favor assisted suicide. He believed it could be regulated, but he has changed his mind, and he is no longer, he's now an opponent of assisted suicide. and he's been speaking all around the world about it. And he has had a look at the data from Holland on suicide committed in the ordinary way. And he compared the data, and I'm looking at it here in front of me on my screen, looking at the data in 2007, just shortly after assisted suicide was legislated, and 1,300 people died by suicide. In 2019, that figure had risen to 1,800. So that was a 33% rise in death by suicide, excluding assisted suicide
the people who
in
were
Holland
assisted to it.
in that period. So some of the proponents of assisted suicide will claim that allowing people to choose the time of their death themselves, either by their own hand, which is assisted suicide, or with help from a physician who will actually give them the injection or the poison, which is called euthanasia. It's been argued that that will actually help reduce the suicide rate because people will have some control over it. And so because they know they can turn to suicide, they won't take their life prematurely. But in fact, the data suggests that is not the case. Once a government has legislated for assisted suicide, the culture of death pervades the community, and so people more readily turn to suicide when the going gets tough.
Well, it does appear that the data completely contradicts that argument, and that argument has been made here in support of Gino Kelly's bill. Now,
yes, I've heard it. Yes.
So effectively, it's opening the door to a much higher suicide rate. But within the bill itself, even if we sort of detach that, the culture that this legislation is going to affect, Kelly's bill does appear extraordinarily broad.
It is very broad indeed. As I've said, it doesn't suggest any time frame. So the person doesn't need to be, terminally ill in the sense of 2 weeks or 3 weeks from death. People can be terminally ill for quite a number of years now with some of the newer medications that actually hold cancers static, yes. Even when they've spread. So the person may be several years, months, years from death. The other thing it doesn't do, it doesn't allow for any sort of psychiatric evaluation of the person. And we know that when people are depressed, and a lot of people with serious physical illness develop clinical depression. And when people are clinically depressed, they become suicidal. And it's treatable with medication and with psychological interventions. But there is no mention of that whatsoever in the bill. There's no evaluation by an expert in evaluating suicidality. And that's a huge gap in it as well.
So there's no psychiatric intervention, no talk of psychiatric help, no psychiatrist mentioned in the bill.
No, and indeed, no psychiatrist mentioned in the bill. And studies from other countries that have examined people who with cancer are suicidal and have suicidal thoughts, it's found that they're overwhelmingly suffering from depression. So the first thing you would want to do is to make sure that the person isn't requesting suicide in the context of a treatable psychiatric illness, i.e. depression, and there is no provision for that in the bill.
So effectively what this bill is going to do is it will legislate to kill people who are suffering from depression rather than suffering from their terminal illness.
Yes, that is correct. That is correct. All it takes is the person to say that they're suffering. It doesn't even have the word suffering hugely in it. It doesn't even have suffering mentioned in the bill. It just says they have to be diagnosed as being terminally ill by 2 doctors, and that's all.
So what this is a license to kill the terminally ill. That's an extraordinary piece of legislation, and that piece of legislation has been voted into a hearing in the Seanad and voted for by the Minister for Justice the leader of Fine Gael, and several other figures who one would have thought would have read the bill.
And the minister, the current Minister for Health.
Mr. Donnelly.
Yes.
Extraordinary. That's just shocking. Is there any opposition to the idea, never mind opposition to this bill, which seems to be negligible anyway, but is there opposition to the idea of euthanasia or assisted suicide?
Well, there is in the medical profession, both internationally and in Ireland. Internationally, the World Medical Association have opposed assisted suicide, and the World Medical Association are part of the WHO. So they've opposed it, and the American Medical Association opposes it as well. And here in Ireland, the Royal College of Physicians, and we do have a Royal College, it may be a misnomer, but the College of Physicians in Ireland is called the Royal College of Physicians. And it has come out overwhelmingly opposed to it. In fact, last week, or the week before, I can't remember which, their president said they took a poll on it and only 25% of their members supported it, 75% came out against it. And the palliative care physicians have come out opposed to it as well. They signed a letter, they sent a letter to the TDs, and including the Minister for Health, and virtually all of the palliative care physicians signed it. A lot of the geriatricians are opposed as well. We're waiting to hear from the IMO. They're meeting, the Irish Medical Organisation is meeting fairly soon, and we have to wait and see what they will say. So the people that count, the palliative care physicians, who are the big group that this is going to affect,
Yes.
are overwhelmingly opposed to it.
They're the people who directly will be dealing with people.
They are the people who will be expected to dole out the poison. Yes.
And they don't want to do this.
And they don't want to do that.
They don't want to be turned into Harold Shipman.
No.
And that one might understand. Can I get you, for the sake of our audience, to clarify the difference between assisted suicide and euthanasia?
Assisted suicide is where the person takes their own life. The assisted bit comes from the medication that the GP or whatever doctor is involved will prescribe for them. So they'll go and they'll get their medication, they'll get the stuff that is going to kill them, but they will take it themselves. Euthanasia is where the doctor actually administers it, often usually by injection.
Okay. So the euthanasia is where the doctor has a very active involvement. They're not passively involved as in prescribing. They get actively involved, and
they're the ones who do it.
They stick the needle in the arm.
Yes.
So this is counter to what obviously the majority of doctors seem to want. It will affect medicine, won't it? I mean,
well, of course it will, because if people if people feel they can die and they're allowed to die by suicide, by euthanasia, they are likely to say, and indeed one person that I read something about in Holland said the most difficult thing is trying to dissuade people, because they say, who are you to tell me how I should die or when I should die? What right do you have to take my autonomy from me? So a bit like abortion, this has become about autonomy. It's what I want for myself and what I think is best for me. And so what right do you as a doctor have to tell me when I should and shouldn't die, and how I should and shouldn't die? The problem, of course, with that is that what doctor wants to be the person to administer the drug? What doctor wants to have to explain to patients that, look, I'm not in favor of this, but I've had to do it? What doctor wants to be in that position? And I think patients will find it very difficult if they know that a doctor treating them has been involved in euthanasia. Yes. You want to know that your doctor is going to do all they can to save your life.
It must be making it very difficult.
And they want to know that your doctor is going to give you any pain relief that's necessary. And this is the nub of it. You see, people have been misled that the term death with dignity forgets that most people in Ireland who die do so with dignity. I've had quite a lot of dealings with palliative care physicians in recent years, and in my experience of them, they are willing to do everything that's necessary to relieve pain. The comfort of the patient is the main thing. They don't want ending the life of the patient to be their primary goal. Their primary goal is easing pain, easing suffering, and giving the necessary medications to do that. And that is their goal. And that is often forgotten. So people who die in Ireland from cancer or from other conditions don't need to be in pain, because in my direct experience, these palliative care physicians are willing to give whatever is necessary to keep somebody comfortable so they will not die in interminable pain.
And just to clarify, there is an immense difference between easing the patient's passage with analgesia and not having pain, making sure the patient, that person, isn't in pain, and deliberately killing them.
Oh, there is the world and his wife of difference between those two. There is a huge distinction. But the impression is being created that palliative care that people are dying, screaming and roaring in pain, having difficulties breathing without getting any relief, and all of that. And that is just not the case. And palliative care physicians will hang. That's their raison d'etre. It is to relieve the suffering of the person.
There are members of the general public saying, I wouldn't want to die screaming in agony. I wouldn't want to die choking, and they believe that this is what's happening.
That's right. And we have to quell that notion. And if you speak to palliative care physicians and indeed geriatricians like Des O'Neill, the professor of geriatrics at Trinity College based in Telehospital, people like him will say, we do everything we can to ease suffering. Our intention isn't to kill people. We're not about killing people. We're about easing suffering. And we do that to the best of our ability.
And to get back to what you were saying about making that it's difficult for a patient with anything else, if they go to a doctor who is actively involved, who has been involved in euthanasia, how do you, if you're an older person, as we all will be, I hope, if you feel you're suffering from depression, go to your doctor and say, I'm depressed. I think I need help. I don't want to die. Please, I'm not asking for euthanasia. How do you trust that he's not trying to sell you that, or she's not trying to sell you that?
That's the problem. There's a case on record in the last week or so in Canada of a young man with a neuromuscular condition. And he has been offered euthanasia so many times.
Offered it.
And he is now taking a case against the physicians because they're threatening to discharge him from hospital and to send him out, and he has nowhere to go. They're threatening to discharge him if he doesn't opt for this, and he doesn't want to die by assisted suicide or euthanasia. He wants to die naturally, comfortably in bed when his time comes, and so he's taking a case in Canada.
And that's shocking, that an ill and vulnerable man has to take a legal case to stop them killing him.
Yes, it is. It's appalling.
It's barbaric.
It is appalling.
Do you think that's where we're going with Gina Kelly's bill?
Well, you see, they'll accuse me of scaremongering. And they'll say, this isn't, he has said there are precautions, there are safety nets. I couldn't see any safety net in the valve. But even if there were safety nets in the original legislation in Holland. And a very interesting man, and again, I'm looking here on my screen at his name, Dr. Bert Kaiser, Keizer. And he's a 73-year-old. He's a former philosopher, and he did medicine late in life and became a geriatrician. And he now works for the End of Life Clinic somewhere in Holland, probably The Hague. And this started as a clinic run by the Right to Die Society, and he started work there back in 2000, before 2002, which is when euthanasia was legalized in Holland. And he was one of the first people. He was doing euthanasia ever before it was legalized in Holland.
The Dutch
And
experience is slightly different to ours, isn't it? Their doctors had advanced the idea ahead of legislation, and the courts
they
refused
had,
to.
that's right. And he took the life of a man who had lung cancer, and he reported himself, and he wasn't he wasn't charged with any offense. And then the law was enacted, and he has been euthanizing people since then. And he says, and he welcomes it, but he says that the number of people dying by euthanasia has grown from 2000, in the year 2002 when the law was first enacted, now to 6,600 in 2017. So that's a huge jump. That's over a threefold jump in 10 years. And he says there is a slippery slope, as does Professor Bohr, the person who once supported Kaiser but who no longer does.
Kaiser doesn't mind. Kaiser doesn't mind the slip. Just to clarify, Dr. Kaiser doesn't mind the slippery slope.
No, he doesn't mind. He embraces it. He thinks it's a good thing.
Yeah, but he says it's there.
And in Holland now, a quarter of all deaths are either directly caused by euthanasia or by what they call palliative sedation. It's where they sedate somebody and then don't feed them or hydrate them.
Liverpool pathway.
So it's a kind of they're actively sedated, but they're not given any hydration, so they die of starvation and thirst, effectively. Starvation and dehydration. So a quarter of people, of all deaths now in Holland, are induced either by euthanasia or by this palliative sedation. 4.2% are directly caused by euthanasia. So that's a huge change. And he wrote an article in the Dutch Medical Association journal about a month ago on this topic. And he says, and I quote it here, after the turn of the last century, meaning the 20th century, what our British colleagues had predicted years earlier with unconcealed complacency happened. Those who embark on euthanasia venture down a slippery slope along which you irrevocably slide down to the random killing of defenseless, sick people. With every limit we set ourselves, there is a possibility to cross it. And so it was with euthanasia. We started with the terminally ill, but also among the chronically ill, it turned out to be hopeless and unbearable suffering that was legal. Subsequently, people with incipient dementia, psychiatric patients, people with advanced dementia, elderly who struggled with the accumulation of old age complaints, and finally the elderly who, although not suffering from a disabling or limiting disease, still find that their life no longer has content. It is true that we now provide euthanasia to people to whom we had said a little indignantly 20 years ago, come on, this is really impossible. And that's coming from a man who was doing euthanasia before it was legal, and who now continues to think it's a good idea.
That's absolutely shocking. When you
and he then goes on to talk about expanding euthanasia to people like who long for death. He said doubly disabled children, or to prisoners serving life sentences, to prisoners in prison serving life sentences.
That's extraordinary. The life sentence basically replaced the death sentence, which is illegal in the EU. No
Yes,
EU country
yes.
can have the death sentence. So
So,
effectively, the Netherlands is going to, under this gentleman, is going to reinstate it.
yes, that's in a different guise, in the guise of compassion. And interestingly, some of the death penalty campaigners in the past have said, well, it's better to have your life shortened in this way than to suffer in prison. And this is it now being reborn again. So, when people say that, accuse people like me of scaremongering, they should read what a man who's a current euthanist
Yes.
in Holland and who embraces it and welcomes it is saying and has said. And he talks about the slippery slope. But as I say, he thinks it's a good idea.
In fact, it's almost unfair to call it a slippery slope. It is effectively jumping off a cliff. And Gino Kelly's bill appears to be that leap, because at least they're referring to hopeless suffering, that they allowed it then for hopeless suffering. We're not even doing that in this bill. This bill
No,
just
we're
says
not. No.
terminally ill.
No,
So
we're not doing that, as you have said. And of course, if the culture becomes accustomed to the idea that anybody who has a terminal illness of some sort is entitled to have their life ended, we will have a culture that becomes very complacent and will no longer be horrified by it. And
I
as Kaiser said, the people that said, "Come on, this is really impossible," will see that what they thought was once impossible has now been made possible.
and it's not just that it will be offered. The gentleman, that young man in Canada, they are basically insisting upon it.
They are, and they may well be driven by some recent work from Canada that was published in the Canadian Medical Journal in 2019, examining the cost implications of medically assisted dying. And this paper, published in the Canadian Medical Journal, calculated that the savings in health cost was between 34 million and 138 million annually. And this was far exceeding the cost of implementing the practice. So the country was actually saving between 34 million and 138 million Canadian dollars per year with the assisted suicide legislation, because of course you didn't have to provide care for people with life-threatening terminal
No
illness.
physicians, no nurses, no beds, no
That's right.
drugs, no palliative care. So and the cost of killing someone is rather low.
Is cheaper than that. Yeah.
So Mr. Kelly's bill might well be the cheaper option for the government.
That's one of the concerns that one would have. And of course, there's also, the issue of coercion is a big one, Paddy, and that is mentioned. I've heard Des O'Neill and the palliative care physicians speak about coercion. Coercion might come from others who might say, Mom, you're 85, you've had a good innings, maybe it's time to think about going.
Uncle
But,
Paddy, you're getting
but
old.
it may not come from others. It may be that you feel a subtle kind of pressure, that you are a burden on others and you don't want to burden others by, needing a bed in hospital or needing to be looked after or having a home help coming in, that maybe others are more deserving of you. And after all, you've had a lived life. That's the term that's used in euthanasia speak and assisted suicide speak. You've had a lived life. Now is the time maybe to forget about living life anymore and do the decent thing and end it so that somebody else can have your home help. And
And of course, the strong never understand that the vulnerable are easily coerced.
oh, indeed.
We don't understand how people sign confessions. We don't understand how people admit to things they didn't do.
Yes.
But the weak are easily coerced. It takes great strength to stand up. So if there's somebody subtly doing it over a period of months, people will be in grave danger. And there doesn't appear to be any safeguards whatsoever in Kelly's bill.
No, there are none, apart from two doctors having to say that the person is competent to make the decision. But of course, what if somebody then develops dementia? Um,
Yes.
will that competence still pertain? You know, will that decision that was made when they were competent still pertain? They're no longer competent, and they're not competent one way or the other. So can they still be euthanized? There's a case recently in Holland where a woman who had dementia, you probably know about this, you may have read about it in the newspapers, had made a decision that she wanted assisted suicide. She was competent to do so at the time. She then developed dementia, and it was decided that she was going to be euthanized, and she fought the injection and had to be held down to be given it. And there was a hearing about that. The case actually went to court, and the doctor was exonerated because the judge felt that she had made the decision when she was competent, and so it should still pertain. But who knows if she had been asked now to make it in her, you know.
In a sense, she was asked. She refused the needle. She struggled.
Yes, she
Although
fought
drugged.
against it. She did. So she showed behavioural evidence of not wanting it, but it went ahead with the help of the assistance of her family.
It's absolutely shocking when you think of it.
Yes,
An old woman held down in the bed by her family
yes,
as a doctor inserted a needle in her arm to kill her.
yes, yes.
If we
And
saw it,
some of the listeners, the webinar this evening, Paddy, may not believe that, but it's all in the public
it's in the
domain if
public domain. It's in the
people
public
want
domain.
to search it, you know.
You can check it. They don't need links from us.
No.
That happened, and that's practice, and that doctor was exonerated by a court, which means that that's now established practice in the Netherlands.
Yes.
We said this changes medicine, but it changes doctors, doesn't it? Because it changes who's going to come into medicine.
It does. Most doctors come into medicine because they're altruistic. They want to help people. They want to make people who are ill better. If they don't get better, they want to just help them live out their days in contentment and peace, free from pain. But that's all gone now, and the role of doctors now seems to be to carry out whatever the person requests. And we don't know if there are conscience clause. I mean, there's no conscience clause. There's nothing about conscience in Jean O'Kelly's bill. Can doctors refuse to do it? Or will it be the same as the abortion legislation, where you have to refer somebody on to a doctor who will do the action, who will carry out the act if you yourself disapprove of it? So we don't know what the conscience parameters are going to be, if any.
If any. So right now, there's no conscience safeguard in the bill. There's an utter lack of safeguards for the vulnerable. It appears to be a very, very, even if one agreed with euthanasia, which I don't, this appears to be a shocking bill.
Yes. I mean, at least the bills in Holland and Belgium started out as unbearable suffering, diagnosed terminal illness, so many, death within such and such a period. But this bill contains nothing like that whatsoever, sadly.
This is a stripped down, naked attempt to grant the power of killing to doctors who don't want it.
Yes.
That's shocking.
To impose it upon doctors who don't want it.
Upon doctors who don't want
and
it.
The language that they're using is Orwellian, because it's called, a death with dignity bill. And people that I know who have died all died with dignity. We all know loved ones who have passed away, and death has, and we do dying very well in Ireland, and we do ensure people die, in the best. We talk about a good death in Ireland, that people had a nice death, but this is stripping that away, and it's assuming that the death is always difficult, and that anybody who wants should have their life ended when they want it. And yet psychiatrists like me are out there fighting against suicide every day of the week. We are seeing people who are suicidal. We're encouraging them to see the positive. We're offering them treatments. We're taking them into hospital. And yet the state is considering legalizing suicide for another group of people. So how can we honestly and with any logic say that certain suicides are bad and certain suicides are good? And that's effectively what the state is going to be saying. It doesn't make any sense. And it's a recipe for disaster.
And the impossibility of that and the disaster of that is seen by the figures that you quoted, where you get a 1/3 rise in a very short space of time in actual suicide.
Yes, that's and a 300% rise in according to the a 300% rise in the numbers being euthanized, and a 30% increase in suicide, according to TO4.
Which brings us to that extraordinary figure from Holland, which I think
yes.
that you brought up, that 25%, 1/4 of those who die in Holland this year, in the Netherlands this year, will die from some form of euthanasia, either
yes.
or active.
Yes, yes.
That bespeaks a dramatic, an extraordinary change in medicine. That is that what we're facing here? If Kelly's bill is voted through.
Yes. That is the concern, that you know the palliative sedation would also become more acceptable than heretofore, and that is now that is why the numbers in Holland have gone up. Why 25% of all deaths are induced either by euthanasia or by palliative sedation.
You mentioned several times the language. You called it euthanasia speak. Can you give us some examples of that? Because I think they distort, like many modern campaigns, they pick their language very carefully in order to get a certain set of ideas across.
Well, of course, as I've already said, of course, death with dignity in this one.
Which says that other deaths don't have dignity. Death without being assisted isn't dignified anymore.
No. Choice is a big thing. Choice, autonomy. This is my choice. We have to respect people's autonomy, people's choices and preferences.
Choices and preferences, even if, as I was 10 years ago, suffering from horrendous depression. You know, obviously Kelly's bill doesn't deal with that, as you said.
No. So the language that's being used, and euthanasia isn't used in relation to it. Assisted suicide isn't even being used. It's death with dignity. And so, you know, it's kind of it's portrayed as being kind of gentle. And who wouldn't want death with dignity? You know,
who could
it's not something. Nobody wants death with indignity. You know, so it becomes impossible to oppose it. To oppose a death with dignity bill.
Yes.
If you interpret it according to the way that the words are used. If you see behind the words and behind the Orwellian speak, you realize that it's actually euthanasia and assisted suicide, and it's death being hastened, and being deliberately induced in vulnerable people.
That use of language is, in a sense, an effort to curtail debate. But we're not having much of a debate here, are we?
No, we are.
It seems to be happening in lockdown very fast, with no real debate in the Oireachtas.
No. And I mean, when the Mary Fleming case went before the Supreme Court a few years ago, they did a very fine response to it. About 4 or 5 years ago, only a very fine response, and they drew on all of the international literature and the concerns that people have about it, and articulated it very powerfully in their judgment. So I think you know, again, the listeners to this webinar should try and get access to the judgment in the Mary Fleming Supreme Court case. I think it was Judge Denham wrote.
Yes, she did.
I think.
Yes. I have a copy of it somewhere. And she very wisely refused to legislate from the bench and said it was an issue for the Oireachtas. But
Yes,
meantime, there was a debate in Westminster on this, and the debate was superb from
yes,
both sides. There were really good contributions, but it
yes.
lost in Westminster 2-1.
Yes, and Westminster is still debating it. They have a special committee hearing on it, and in fact, Theo Bore was over a few weeks
Yes,
ago speaking at that to that committee, and I read some of what he wrote there.
I presume if we get that far, if Kelly's bill fails, we'll probably have another constitutional assembly or legislative assembly or some group of hand-picked citizens in a quasi-parliament again.
That is the problem. I mean, the best would be an Oireachtas committee similar to the abortion one, and although they ignored the findings and the overwhelming evidence, on this occasion, there would be, I think, opponents from abroad could come in, like Dr. Bohr, could be brought in. There's also a very good psychiatrist, and as I'm speaking, I'm trying to bring up his name here, but I cannot.
We might get a slightly more competent chairperson.
There's a psychiatrist who is an American psychiatrist.
Okay.
He's New York Jewish. He's utterly and completely opposed to assisted suicide. And I heard him
He
speak.
can't be accused of being a foot soldier of the Catholic Church.
No, he cannot indeed. And I think Sarker is his name, but I'm not certain. But he persuaded the American Psychiatric Association to oppose it. And he's gone around Europe trying to persuade governments to oppose assisted suicide. And he gives a very, very powerful talk, particularly on how on the slippery slope and in relation to psychiatric problems, in relation to psychiatric patients. But he has been very vocal, and he would be somebody that could speak to an all-party Oireachtas committee if we get to that stage.
If we're allowed to get to that stage. Right
if
now,
we're allowed to get to that stage.
where he is,
I'll try and bring up his name here as I speak. But I may not be able to do. I meant to do it earlier when I was reading round it, but I had so much work to do in preparing that I
know this is a very busy week for you. So I don't want to hold you inside this webinar for the night either, because I know you have a lot of things you need to get done.
Yes.
You are in the process of completing a book.
Yes.
Just before we finish, takeouts for our audience who may be afraid that if this bill fails, they will die in agony, that their loved ones may die in agony. That isn't the case.
That is a myth that has to be scotched. So if they are speaking to their TDs, and I hope they are, that myth can be scotched. You need only read. They should read the letter from the palliative care physicians that was published in the Irish Times, I think.
Extraordinary. Yeah.
Last week.
That the paper of propaganda actually published it.
Now, I think it was that paper. I didn't see it in the Irish Times. I saw it on Gript. I saw it in another news forum.
Respectable people never see the Irish Times.
But it's available if you just Google palliative care physicians opposed to assisted suicide Ireland. I'm sure you'll get it up on your internet.
That's absolutely wonderful. Professor Casey, thank you so much for tonight.
Paddy, if there are any questions coming in, I'm happy to take a few minutes to answer them before we sign off.
It may be my internet, but the chat box isn't showing any at the moment, but that might be solely my internet. And if it is, I apologize to anyone who put up a question. I'm on a hotspot on a phone, which is hanging out a window. I live in a digital black hole. So that's the only apology I can give. So, Professor Casey, thank you very much.
It's a pleasure, Paddy, and thank you for all of your questions and observations and for hosting this.
Thank you very much. Good night.
Good night.